All right, welcome back, everybody. We are going to get started with our first presenter today. It's my pleasure to introduce Dr. Violet Borowitz, pediatric hematologist oncologist with Carilion Children since 2014. In addition to caring directly for pediatric oncology patients and survivors, Dr. Borowitz is the pediatric liaison for Carilion Hospice, as well as the medical director for Care Connection. She is an associate professor in the Department of Pediatrics and VTC School of Medicine and an assistant professor in the Department of Pediatrics at Edward Via College of Osteopathic Medicine. In 2019, she became an associate program director for the VTC Pediatric Residency Program. A very big thank you to Dr. Borowitz for taking time out of her busy schedule to share her expertise with us today and provide an overview of childhood cancer. Welcome, Dr. Borowitz.
Thank you. So as mentioned, I'm going to go over just a brief overview of childhood cancer. I do have no financial disclosures. The objective of this talk is to really go through the most common types of childhood cancer that we see and to review how frequently childhood cancer occurs, how childhood cancer differs from adult cancers, what treatment entails for a patient, what our survival rates look like, and what survivorship looks like. So just a brief overview of childhood cancer. Childhood cancer, we say, as this general term for any child who has cancer, but it really isn't a catch-all diagnosis. We have so many different types and variations of cancer that we see, different treatments, different things that come into play when it comes to kids who have cancer. So really childhood cancer is just does not define enough of what these kids go through. Cancer is not biased by race, gender, or socioeconomic status. 47 children are diagnosed every day in the United States. Most of the current standard treatments that we have now were approved over 30 years ago. On average, clinical trials for children begin 6.5 years after adult trials have been conducted. 90% of children and adolescents who are diagnosed are treated within one of the 200 children oncology group hospitals that exist, with about 100 active clinical trials ongoing at these COG hospitals. The Children's Oncology Group is a international cooperative group that looks at studying childhood cancer treatments and also looking at late effects in childhood cancer survivorship in terms of trying to improve what we are doing for kids with cancer. As I mentioned, there are a lot of different subtypes, and even within the different types of cancer, there is also multiple types that may be defined within that. We have acute lymphoblastic leukemia, and that can be B cell or T cell. We have acute myeloid leukemia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, neuroblastoma, Wilms tumor, hepatoblastoma, which is a tumor of the liver, retinoblastoma, which is a tumor of the eye, various types of brain tumors, rhabdomyosarcoma, osteosarcoma, Ewing sarcoma, soft tissue sarcoma, and germ cell tumors. Again, even within these categories, there may be multiple different subtypes. Within AML, or acute myeloid leukemia, there are 7 different types, which has 7 different types of treatment that these patients may receive. From the types, leukemia is the most common type that we do see. 28% of children who are diagnosed with cancer have leukemia. Tumors within the central nervous system, so our brain tumors and spine tumors, those are the most common solid tumor that's seen. About 26% of patients in pediatrics have central nervous system tumors. Lymphomas are the next at 12%, and then neuroblastoma is the most common solid tumor that's diagnosed outside of the central nervous system. About 6% per year are diagnosed with neuroblastoma. So just to go over some statistics, in 2023, it was estimated that a little over 15,000 children and adolescents between the ages of 0 and 19 would be diagnosed with cancer. It's estimated that a little over 10% of those would die of the disease in the US. Among children who are 0 to 14, almost 10,000 of those were diagnosed with, again, a little over 10% who would die from it. And then adolescents considered the ages of between 15 and 19, it was estimated that a little over 5,000 would be diagnosed and 550 would die from the disease. So children versus adolescents. Children, again, defining them between 0 and 14 years. The cancer incident rate actually stabilized between 2010 and 2019, so there was no growth in the incidence of cancer during that time frame. Leukemia is the most common diagnosis in that age group. Adolescents, however, with the 15 to 19, we are still seeing a cancer incident rate that continues to rise about 1% per year. Lymphoma is more common in the older age group. So what are some things that we look at between children and adults? Big thing is we say often in pediatrics, children are not little adults. There is a huge difference in how we treat children versus adults in general in medicine. So we know that a lot of these cancers that get diagnosed are not strongly linked to lifestyle or environmental factors that we see in adults. Kids are not getting cancer because of smoking or tobacco exposure or alcohol or diet. Only a small number of those are caused by DNA changes that can be seen in the tumor itself. Treatments are often more successful in pediatrics. And a lot of this is due to the fact that we are a lot more aggressive with a lot of our treatments because kids are generally healthy at the time of diagnoses. So when adults get diagnosed, oftentimes they may have other conditions like high blood pressure, diabetes, high cholesterol that kind of play into how well they are going to be able to receive chemotherapy. Whereas most pediatric patients are pretty healthy when they are initially diagnosed. Again, another big difference, as I mentioned, is that the children's oncology group. So most children actually do receive treatment within pediatric cancer centers. They also, we initiate treatment a lot more rapidly. Most leukemia patients will get treatment started within 5 days of diagnosis. Usually we try to aim for as soon as possible once we know what kind of cancer they have. There can be communication barriers, unfortunately, with children, just because of their inability sometimes to communicate what their symptoms are. That can lead to a delay in diagnosis. So sometimes these kids are actually a little further along in their staging because we don't always pick it up quickly enough if they cannot tell us what symptoms they're experiencing. And there are sometimes that kids are very resilient, and sometimes those symptoms are brushed off for other reasons because they are able to play and still kind of adapt to whatever they're experiencing. There is also a greater concern for long-term side effects because kids are now living decades after their course of treatment is completed, and we are seeing a lot more late effects that are affecting our pediatric population. And there's a lot of difficulty in research because kids' research in children tend to lag behind adult research. There's also a lot more rarity with some of the subtypes, and so getting more specific research in that realm is also very difficult. So going through some treatments, typically we give chemotherapy through a central line. Some may also receive oral chemotherapy or other medications at home. And then some do require intrathecal chemotherapy, which is delivered to their spinal fluid via a lumbar puncture or spinal tap. So for any women out there who have had children and may have had epidurals, it's very similar to that process where we're doing a spinal tap to be able to deliver chemotherapy directly to their spinal fluid. And this is in cases of kids who have leukemia or certain types of lymphoma where we are trying to treat or pre-treat any disease that may go to that area, that may exist there or may go to that area. Again, treatment really varies based on their cancer type, based on their phase of treatment. Some patients require inpatient treatment, and so they are admitted to the hospital. Sometimes it's because they need to get additional hydration through their central line. Sometimes their chemotherapies are longer infusions that we cannot complete in a clinic day. Some of our chemotherapies infuse over 24 hours, sometimes over 48 hours. So due to those length of times, they do need to be admitted to the hospital. We do drug excretion monitoring for some of these chemotherapy drugs that we give. These kids for chemotherapy alone may be in the hospital anywhere between 2 or 5 or more days during their treatment. And then they also may be in the hospital extended out from the completion of therapy due to side effects that they may experience from their treatments. Outpatient treatment, the length of time can vary anywhere between just a push drug that's given over a few minutes to requiring to be there all day for various chemos. And again, frequency of office visits can vary. So they can be there 1 to 5 days per week, every week. They may be there 1 to 5 days per week, every 3 to 4 weeks. They may be there monthly clinic visits. It really depends on where they are in their treatment and what treatment they're receiving for their diagnosis. Some patients may even need radiation therapy on top of that. So they may get radiation therapy Monday through Friday for anywhere between 6 and 30 days, depending on their type of tumor. And then additionally, some patients will need surgery for their tumor and will require an extended period of recovery postoperatively. And then depending on what type of cancer they have, again, the surgery may happen prior to the start of chemotherapy or radiation, or it may occur in the middle of treatment as well. Along with their treatment, because we are giving toxic chemotherapy to be able to fight these cancers, they often have appointments they have to come to the office outside of their chemotherapy days. So they are getting sick visits because they have a fever or they may need a blood or platelet transfusion. All of these are side effects secondary to their treatment. We know that our chemotherapy will affect cells that are growing fast, but it doesn't differentiate between good and bad cells. So this can affect their blood counts, and their blood counts can go lower, requiring this blood transfusion and also making them more at risk for infection because their white blood cells is low as well. Sometimes they may even need to be admitted to the hospital if they're severely immunocompromised. If their white count is very low and they have a fever, oftentimes we have to have them admitted outside of their chemotherapy for an extended period of time until they recover from that as well. So just to go into some information about survival rates. So in the mid-70s, only 58% of children, 65% of adolescents actually survived at least 5 years from diagnosis. That has significantly improved with all the research that has been done, especially through the Children's Oncology Group. The data from between the 2013 to 2019 5-year survival rate data, 83.2% of children who were less than a year of age survived, with a higher percentage of children, 87.8%, for kids who are ages 1 to 4. It does go a little bit lower at about 85% for those between ages 5 and 14, and about 87% for children between ages of 15 and 19. So our data has shown that we have had significant improvement in our survival rates, which also means we have a significant increase in our cancer survivors that are experiencing late effects from treatment. We have seen dramatic improvement for several of our cancers. The 5-year survival rate for ALL, so acute lymphoblastic leukemia, was 57% in 1975 and now 92.1% between that 2013 and 2019 timeframe. Those with non-Hodgkin's lymphoma in 1975, their survival was 43%, and now it's 91.4%. However, even with this, some of our cancers we have not actually advanced pretty significantly due to lack of advancements in therapies that exist for cancer. There is a specific type of brain tumor called diffuse intrinsic pontine glioma. 50% of those patients survive less than 1 year from the time of diagnosis. Only 10% of them will survive 2 years from diagnosis. 5-year survival for the ALL that I mentioned in children is a lot higher at 92%, but the data for adolescents was only 77%. And then Ewing survival rate, which is a type of bone tumor, 5-year was 78% for children and 64% for adolescents. So some of our tumors really haven't had progression in our treatments because there just hasn't been newer chemotherapies that have been available for these cancers. We do continue to try to do research. Our goal is to try to improve outcomes as well as improve the late effects and secondary malignancies that our patients are seeing. The cancer mortality rate declined by more than 50% between 1975 and 2020. In 1975, it was 5.1 per 100,000 children and adolescents, and in 2020, it was 2.1 per 100,000 children and adolescents. So just some quick information about survivorship. As of January 1st, 2020, there was an estimated almost 500,000 survivors of childhood and adolescent cancers that are estimated to be alive in the United States. Approximately 1 in 750 young adults. The number of survivors continue to increase, and the incidence has been rising slightly in recent decades because their survival rates are overall improving. They do still need regular medical care because of their increased risk of complications that's related to disease or treatment. So these are the late effects that I mentioned. They can develop secondary cancers. They may require joint replacements because of side effects from therapies such as avascular necrosis that can damage their joints. They can develop hearing loss. They can develop congestive heart failure. And these late effects occur at a much younger age than when we see them normally in adults that have not gone through this, experiencing this, and later in life. And so it's really important, the research that's being done into cancer survivorship, because we are seeing so much of this now that our cancer survivor rates have improved. More than 50% of our pediatric cancer survivors have experienced a severe or disabling complication, or even death by the time they reach the age of 50, known as premature aging. 73% of them will have a chronic health condition, and 42% will likely experience a severe, disabling, or life-threatening condition, or even death. We know even with survivorship, there's a lot of learning problems that can come hand in hand with this, which is where our education navigators have made a huge impact on our patient population with helping them succeed in school. We know that there's problems neurocognitively with processing, with handwriting, spelling, reading, vocabulary, math, concentration, attention span, their ability to complete tasks on time, memory. I've had, currently I have a 22-year-old patient who is attending community college and has recently told me that he really is struggling with his memory and ability to process and remember things. Planning, organization, problem solving, social skills. So there's a lot of things that go into the survivorship piece of this, where these young adults are needing more assistance because of the things that they've gone through. Other things to think about with cancer survivorship is future fertility. We know that future fertility can be impacted. We know that some parents and families want to try to plan for that. There have been ongoing studies for fertility preservation, both testicular and ovarian. There have been multiple things that have been done to try to preserve ovarian function. I know there are centers that are also able to provide testicular ovarian biopsy and preservation of their fertility function as much as possible. It's also important to consider that peer support is very important for survivorship, and so having a peer group of cancer survivors is something that is incredibly important for our cancer survivors, because they are all experiencing things that they don't always necessarily know who they can talk to or how they can get help. Mental health is another concern. Anxiety, depression, post-traumatic stress disorder is very big in our patient population, especially when they go through it at a young age and don't really get much of a say in what is happening to them. And then psychosocial support. So finances, education, the occupational impacts and transition to independence. Some of our patients have a hard time with being able to function full-time in a job because of late effects that they're experiencing, whether it be seizures or something else that is impacting their ability to function on a daily basis. Again, the Children's Oncology Group does have ongoing research to try to decrease late effects, but we do know that the things that we are doing to get our patients into cancer survivor place is causing a greater impact for their lifelong journey. And so it is really important for all of the cancer survivor research that is still ongoing. I think that's actually all that I have. If there are any questions, I am very happy to answer anything that might come up.
As we wait for questions to come in on the chat, I have a couple of questions to get us started.
Yeah.
So at the beginning of your presentation, you mentioned a central line. Can you explain a little bit about what a central line is and how it's different from a portacath? And then, sorry, it's a long question. And then can children go back to school? Well, I know they can go back to school with a portacath. Do they ever go back to school while they still have a central line?
So yes, so the portacath and the central line are kind of the same thing. So portacath is also considered a central line. Some central lines may be external, so those are Hickmans or Broviacs where they're hanging out, but those patients can attend school even if they have a Broviac or Hickman. But I kind of put central line as a catch-all diagnosis separate from a portacath, or catch-all term separate from a portacath, just because some of our younger children are too small to actually get portacaths. Usually they will definitely not do it under 6 months. And sometimes even under a year, depending on their size, that they have to do an actual external central line. So the big thing with the central lines, because they are external and hanging out, they just have to be, the families actually have to learn to flush those daily with heparin. Whereas a portacath does not need to be flushed every day. The nice thing about a portacath is that when the needle is not in and it's de-accessed, those patients can still go swimming in the ocean. They can still take baths. They can still take showers. They can go swimming in the pool. Central lines that are external, unfortunately, they cannot submerge those in water.
And then we do have a question in the chat. Where are studies being done on late-term side effects?
Where?
Yes, where?
So the Children's Oncology Group has several ongoing studies that are opened at various COG institutions across the United States, and a lot of it is survey based to try to figure out what late effects are being experienced by cancer survivors, as well as what some of our studies are doing is looking at decreasing some of the chemotherapy we're giving to also decrease some of the late effects that we're seeing. So, for example, when I first started training, the leukemia, for example, when they got into maintenance chemotherapy, they were given a vincristine and steroid. Vincristine is an IV chemotherapy and steroid pulse every 4 weeks. As I've gone through, a study was open that looked at comparing that versus doing the vincristine and steroid pulse every 12 weeks so that they're getting less chemotherapy over time. And all of the data showed that it was basically equivocal. And now we have changed what our standard of care is to do those pulses every 12 weeks. So that has helped us know that we can decrease some of the late effects that we're seeing by giving less steroids.
Another question, are there less late-term side effects for cancers such as Wilms versus the more common tumors, or is it about the same?
There are less late effects with certain tumors, yes, just because they do get less chemotherapy, but there is also different late effects. I think for my kids with Wilms tumor are more likely to have something called foot drop from their vincristine, because vincristine can cause what we call a peripheral neuropathy, where they just are not able to pick up their foot while they're walking. And I see that more frequently in our Wilms tumor population because they get so much vincristine versus our other populations of patients that don't get as much vincristine. So the late effects may be less in kids who are getting less therapy, but they are also different.
Any other questions? That participant said, thank you, I'm an educator, but also have a Wilms tumor 18-month-old.
Wow. Yes, they really do in general seem to do pretty well because they do get less chemotherapy, but
I have a question. This is kind of specific to your treatment center. So Dr. Borowitz is in Roanoke, Virginia, which is in Southwest Virginia, which is a more rural area. So I know families can travel great distances to come into treatment. So can you give an example of a family who is driving a great distance and how frequently they're needing to do that to get treatment?
Yes, actually right now we have one family who's a teenager who has Hodgkin's, and they live 2 hours from us, and his treatment is there's 5 cycles of it, and his first week it's 3 days in a row that he has to be in clinic, and they're long days. And then the following week he comes back for a 1 day visit to the clinic, and then he gets a break from us, and then he has to come right back again the next week for 3 days in a row. So typically when they're driving those 2 hours, a lot of times our family will actually try to stay them on a McDonald's house to make it a little bit easier on them travel wise, just because of that distance. Some families are not actually able to do that too because of work or for whatever reason. So some of them are actually making that trek daily.
It's tough. It's hard to imagine that
Yeah.
stress on a family.
The furthest family I had coming was 3 hours away.
Okay, we have a question. I know chemo changes the child's taste. Once treatment is completed, how can we encourage better eating habits? It's a great question.
That is an excellent question. One of the things that I have been seeing in our patient population is a trend towards increasing obesity as well because of these significant changes that they go through, because we're constantly so worried about their weight gain, weight loss that they experience during therapy, that we're pushing so much food on them that all of a sudden they come off therapy and we're having trouble keeping up with them. It's really exposure. It's exposure to foods, it's exposure to textures, it's exposure. And so that's really what the big thing is. And I often tell families, like, it's just about continuing to expose these kids to things. I will also say that I had a teenager who will not eat asparagus anymore just because of the peg asparaginase that he got. He was like, the name is just too close and I cannot eat, even though they don't, it's just because of the name, because of the words. He's like, nope, won't do it.
Does their taste ever go back to, or is it changed forever?
Most of them do go back. I have had one who has said it's always changed a little bit, but everyone else has been able to go back.
A question came in: if the chemo were less aggressively paced, would the late effects be less intense?
That is a great question. I don't know, that we have not studied that, because we know that certain tumors do better with the more aggressive pace. So for example, Ewing sarcoma, it was something that used to be, I guess, technically less aggressively paced because it was given every 3 or 4 weeks. And a lot of the data showed that trying to give that every 2 week cycles actually led to better outcomes from a cancer, like being able to get them to become cancer survivors. So part of the problem is trying to get them into that cancer survivor place. We have to do our aggressive treatments.
Sure, that makes sense. Any other questions for Dr. Borowitz? These were great questions. Thank you, guys.
Yeah.
All right, I don't think we have any more questions coming in. Thank you so much for taking the time to be with us this morning and give us this really great, insightful information.
Absolutely. Thank you for having me. It was a pleasure.
So before we go to break, we have a couple videos we're going to show of some survivors who talk about their late effects. One is cognitive late effects, and the other video is social emotional late effects, which will lead us in, when we come back from break, it'll lead us into our topics about late effects. So we will, as we get those up and going, I would love to, if everybody in the chat could tell us where they are watching from, because I know I've gotten a couple emails from folks who are very far away, even in other countries. So we would love to know where you're watching from today.
Hi, I'm Justin Jennings.
I'm Liz, Jack's mom.
At the age of 13, I was diagnosed with,
Myxoid liposarcoma.
and the things I struggle with most with at school is brain fog and walk overload. Basically, too much walk. When I come back from treatments, just piles up too much.
I will say that our school system, through middle school and high school, has worked really well with us. The administrators, the staff, the faculty, the counselors have worked really well with us. A number of his teachers have dealt with this on a personal level, overcoming cancer themselves, and unfortunately having worked with other students in the past with this disease. So they have, unfortunately, a lot of experience. So they've worked really well with us. They're very sympathetic and empathetic, and they give Jack a lot of the resources and time that he needs. But he still needs a lot of extra support and resources, and they do work really well with us in that aspect. But it is something that he struggles with.
Hi, I'm James Mullador. I was diagnosed with acute lymphoblastic leukemia when I was 12. I am now 17, and it really had a little bit of an effect on my life socially because I'm homeschooled, so most of my schooling sort of stayed the same, but where I get most of my social interaction is from my extracurriculars. So I do theater, I do Boy Scouts, I do dance, and all of a sudden I just couldn't do all those things anymore. So I knew I had people on the outside sort of supporting me, but I couldn't see them because I was trapped in my house for a month, 2 months until, actually it was more like 6 months. All these things I loved, the things that kept me going, my performing, I couldn't do. Eventually, about 6 months in my treatment, I did a show, but I couldn't go to rehearsals. So I had to FaceTime in for the entirety of the thing until 7 days before the show, when I actually went into rehearsals. And it was just sort of, it was a struggle. And I really missed my friends and doing all these things. And it has affected me. Like, I think I would be a lot further along as a performer, at least. And I miss those really important years of growing with friends. So a lot of times I find it harder to get close to people and make friends just because those are such formative years, those years from like 12 to 14, where I just was isolated from everyone else. So maybe I've talked too much, but that's sort of my experience with it. I think that's important to know.
All right, so Dr. Borowitz might still be with us. We had one more question come in. She may have already logged off. Oh, she might be. Oh, she is still with us. Excellent. We had a question come in. Because of the negative effects of chemotherapy, can a holistic approach be implemented? I guess for the patient to have a healthier life, less late-term effects, I think is the question.
Yeah, absolutely. I also do pediatric palliative care for our hospital. And so I am a big proponent of trying to bring in other aspects and not just the chemo drugs. So I do think that it can be. There's still some things with complementary alternative medicine that just hasn't been studied. So we don't know impacts long-term on certain things, but I'm a big proponent of trying to do whatever we can to kind of decrease the mental and psychological stress that patients are going through. A lot of times with my families, I tell them, look, my goal is to get you through this, but also to try to keep your life as normal as possible when you're going through something like this. And it's because it is a game changer and a life changer. So trying to keep them on track with school, trying to keep them on track with their life, trying to keep them in those social activities as much as possible is important because it does impact them long term, as we just heard from a patient about what kind of changes that they experience when they're isolated from their friends.